Good afternoon, and welcome to our first CTS talk of the year, and a very special year it is. It is the 100th anniversary of CTS, and this year we are featuring three nationally and internationally known speakers working at the intersections of public life with healthcare, religion, theology, and social systems. I am delighted that you are here, and I'm glad that I know that you'll be glad that you came after you hear our speaker this afternoon. At each of our talks, we follow sort of a similar format. After I do a couple of introductions, introduce our speaker will speak for about 40 minutes or so, and then we'll have a time for Q&A led by our Dean Lozada. And then afterwards, we invite you to just walk down the hallway to the common room for a reception and an opportunity to talk with our guest speaker. Our presenter today is Dr. Hannah Maxey, Associate Professor of Family Medicine and Director of the Bowen Center for Health, Workforce Research and Policy at Indiana University School of Medicine. She is a nationally recognized expert in health workforce policy with more than 2 decades of experience in healthcare and public health. Dr. Maxey has been a licensed dental hygienist in Indiana for over 20 years. She spent nearly a decade practicing in public health clinics prior to pursuing a master's degree in public health policy and management and a doctor of philosophy in the same area. Her experience as a practicing healthcare professional in public health clinics provided perspectives on the intersection and relationship between healthcare and public health, as well as the critical role the health workforce has in ensuring availability and accessibility in both public health and healthcare services. Dr. Maxey has been actively engaged in developing strategies and leading health workforce initiatives within multiple states since 2014. She serves as an expert consultant to the National Governors Association and has worked on issues ranging from health workforce data collection to policy design and implementation. And I will say over the past year, working on her project, which I'm sure she will be talking about, she has become a friend of CTS, for which we are very grateful. So I invite you now to please join me in welcoming Dr. Hannah Maxey.
Well, thank you so much for that generous introduction. As I was preparing for this, I was feeling very anxious. I'd never spoken to a group that are experts in religion and philosophy, and so I was feeling a little overwhelmed. And then I got here, and everybody's sitting in the back, and I'm like, it's just like church, right? So thank you, first of all, for making time on a Thursday afternoon to come to hear about a really important topic, one that I have been working on, actually for this year, but for many years. And before I get started on the topic of mental health and talk about how my work intersected with CTS and where opportunities exist that I see, I want to share a little bit about myself, because I think that will help ground us in the conversation. You see, I am not a mental health professional. I have no formal training in mental health. I also am not a religious leader, and I today was asked by your dean of faculty, did you ever take a theology class or a philosophy class? No, I never had the opportunity to take a philosophy or theology class. I really wish that I had in the course of my academic career, but I didn't get to. So today, I actually was at a presentation earlier this morning at the Indiana State Department of Health, where I was a health workforce research expert and presenting on state policy strategies for recruitment and retention for the workforce. And as I was driving up, I actually came up Martin Luther King all the way, and I passed the Blackburn Health Center, which is at 27th and Martin Luther King. So I told you I was a PK, and your president read my bio, and you're probably thinking, why is a dental hygienist talking to us about mental health? I was a dental hygienist, and I practiced in health centers. And in fact, that health center at 27th and Martin Luther King, the Blackburn Health Center, was the first health center I practiced in. And it was in that health center that I realized the disparities in health that existed within our communities. I had heard about them, but I really had never seen them before in person. It wasn't very long after starting my position as a young dental hygienist in the health center that I started to feel overwhelmed with the disparities that existed. In fact, the truth of the burden and the struggles of the people that I was caring for became overwhelming. There were actually times that I can remember cleaning people's teeth, and if you have had your teeth cleaned, you know the hygienist is sitting there, has glasses and a mask, and I literally was tearing up and tears were falling onto my glasses while I was cleaning someone's teeth and they were sharing with me what they were experiencing and feeling. Some of what they shared was food insecurity, housing insecurity, that they didn't know how they were going to pay childcare so that they could go get additional dental care and still keep their job. Those things, the dental care, I could help them with that, right? What I couldn't help them with was the loneliness that they felt, the despair that they felt. And what I didn't know then, but now, because I am a researcher, know, is that what I was experiencing was vicarious trauma. Those people that I was caring for, I was connecting to them, and their trauma, their hurt, I was taking that on into myself, and that was a trauma to me that I did not understand at the time. And so, mid-2000s, I'm talking again with my father, and I'm saying, Dad, I've got to do more. I've got to do more. I can't do that. I can't keep just cleaning teeth. I can't. I've got to be able to do something to help these people and help them in a way that is going to do something. And you know what he said? Just pray about it. And I need to be honest with you guys. There was a point where I asked my dad, I'm like, Dad, do you think I should go into the ministry? Because I feel really passionate about helping people, and I feel like my faith is like a rock for me. And he's like, you just need to pray about it. And so I did. I had one child, wasn't a dental hygienist, my husband's in grad school, and I'm praying about it. I'm like, God, you just lead me. And at first, guys, I was like, I bet I'm supposed to go to dental school. And that was not the path that God had for me. Though I am smart, chemistry, going back with a child, I realized very quick that wasn't going to be the right fit. I kept praying about it, and doors opened. And those doors were in public health and health policy. And those doors were health policy and healthcare workforce. And I started to develop research interests and expertise in what are those policies, those programs that we develop as states, as academic institutions, as organizations that impact the way our students are prepared to serve different populations, to be out in the community, and to care for others. And so I became very interested in health workforce policy. At first, I was really focused on shortage, and we're going to talk about some of that today, but that led to all different types of policy. And yes, I did a lot of dental workforce policy to start out because that's my area of expertise. But throughout the years, I had so many opportunities and so many incredible people that have touched my life and our lives. In fact, I just am going to share with you all part of our journey has included mental health professionals that CTS has prepared. I believe that all of these experiences have led me to today to speak with you about mental health, about where we're at as a state, and about where I believe opportunities exist for our communities of faith to lean in and be a part. Do you have? Oh, it's over there. Sorry. Thank you for bearing with me. So I want to start and talk about mental health and untreated mental illness. And remember, I told you all, I am not a mental health professional, so you actually have experts on that here at CTS. So if you would like to speak with individuals about mental health, specific mental health conditions, you guys have a team of people that can speak with you about that. What I can speak with you about is how we quantify mental illness around us and the magnitude of the impact of mental illness and untreated mental illness and what that is having here in Indiana and, quite frankly, nationwide. I want to talk about the cost in dollars because, of course, I think that's important for us to do. And then I want to talk about the human cost and the cost in people. This data is the latest information we have. More than a third of Hoosier adults are reporting that feeling symptoms of depression or anxiety. So that's a huge number of adults. A recent report said more than 1.1 million adults in Indiana have untreated mental illness or a mental health condition. So I asked when I got here, how many can this stage hold, right, or this stadium? 400. And we had an event at Lucas Oil Stadium where we talked about how many times you had to fill that stadium with all the people that were struggling with mental illness. This is more people than live in the city of Indianapolis that need access to care and services. The costs monetarily are huge. The recent report put out by the Fairbanks School of Public Health estimates $4.2 billion as the societal cost of untreated mental illness in the state of Indiana. I think I think there's a lot of talk, I'm sure, at CTS as well, about the impact of mental health, mental illness on our youth. And our youth are in crisis. And I think we can't underestimate the extent of that crisis among our teens. So these are just some statistics. This is specifically looking at suicide as the cause of death and looking at the adolescent suicide rate. That is a trend line from 2000 to 2021. And you can see that trend line has just been increasing. These are children, these are young people, 10 to 14 years of age. Recent estimates say 90,000 of our Hoosier youth that are aged 12 to 17, so junior high to high school, have depression. We know from studies that 50% of students with untreated mental illness will go on to develop substance use disorder. And I think there are a lot of things that are contributing to this. I think if you're reading some of the literature, we can talk about social media use, we can talk about some of these things that are in our children's face all the time and every day that are significant challenges right now that we're facing. I think as I was preparing for this talk, I had really not heard of this concept before. But researchers out of Princeton, I think 2 decades back, created a category of death that is called deaths of despair. So these are the number and the rates of deaths that are due to suicide, homicide, and drug or alcohol-induced deaths, and that is called deaths of despair. And so I thought it was good for us to look at those because these deaths of despair represent lost opportunities for intervention, for connection. And unfortunately, we see that that trend line has just been increasing over the last, several years. And you can see Indiana is higher than the nation. As I was preparing for this talk, I also was pulling actually the statistics from other countries and the European Union. Their rates of deaths of despair have actually plateaued and somewhat declined in recent years. But here in the United States, where we have so many resources, our population is experiencing a greater number of deaths of despair. So what are the factors that are contributing to this? And again, I'm prefacing this all with, I am not a mental health professional. But we know that stigma around mental health is impacting individuals' perception of accessing mental health care, perception of themselves and their mental health status, their concerns about potentially accessing care. Stigma is very real, and I think it's not just the stigma that we all think about, okay? I think that we have this perception that our youth don't have necessarily that stigma, that they're growing up around a comfortable environment where we can talk about our well-being and our self-care. I need you all to know that that's not all youth, and that doesn't mean that there isn't stigma within youth. I think we're all aware too that there has been stigma in our faith communities about mental health. There are misperceptions that mental health is not an illness, that we can, if we're stronger, just not struggle with this. From personal experience, I know that you cannot pray your way out of mental health or pray your loved one out of mental illness. As faith communities, we have to work to reduce stigma within ourselves and within those people that we minister to and that we have influence on. That is critically important because those people that are struggling, they need to feel accepted and included, and they need to be able to go to people and have them accept them and point them in the right direction instead of shun them or give them guidance that will not actually help them. I have someone I know who, within the last 2 years, lost a loved one to suicide. That loved one did not go seek care for what we assume is significant depression and a significant depressive disorder because they were counseled that they should pray and that would be resolved for them. We absolutely have to work on addressing stigma within faith-based communities because people come to faith-based communities looking for connection and looking to be accepted and to be assisted and helped. So stigma is huge, and I think we have lots of opportunities around stigma. And I can't underscore how important it is that we work on stigma with our youth and we don't make assumptions that the younger generations culturally are okay talking about mental health. I just don't believe that they are to the extent that we might think. So huge contributing factor is stigma. People that need care are not getting it because they're afraid to go seek it or because they're afraid to admit that they need help. And then the other side of the coin is there are folks that are ready, know they need help, and they can't find anyone to provide care. And that's where we get to workforce, okay? Today, as of today, every single county in the state of Indiana has some form of federal designation as a mental health workforce shortage area. I was just interviewed by WFYI. They're like, are you sure it's every single county? What about Hamilton County? No, there is a shortage in every single county in Indiana. And let me be clear, we've had these shortages for many years. These shortages are not new. They've just progressed to the point that they're impacting everyone from every income level, that many people are having difficulty accessing healthcare services and mental health care services and behavioral health care services. So I'm really excited that I got to connect with CTS, but this shortage is recognized and has been prioritized. In recent years, the state's done a lot of work on mental health care and access through the Division of Mental Health and Addiction and made significant investment. Our legislature has appropriated funds and been working on that. But about a year and a half ago, the Lilly Endowment became very interested in what is going on with the crisis of our workforce shortages in mental and behavioral health here in the state of Indiana. And why is it that we have such strong academic institutions, post-secondary institutions, that are preparing students to go into these fields, but it doesn't seem like our shortages are getting any better. In fact, it feels like they're just getting worse and worse and worse. And so I'm at Indiana University. Now, I need you guys to know, at Indiana University, I am a peon, okay? So the Lilly Endowment came to our president, Pamela Whitten, and said, we want to know what's going on with these shortages. We know IU is a big institution. You guys have lots of programs that are preparing people for mental and behavioral health occupations. We would like IU to put together some study to look at what's going on and why we're having shortages, what's going on in our higher ed institutions, and why are our shortages getting worse if we're cranking out or we're seemingly preparing professionals. And so our president went and looked around, I think, and was like, okay, who do we have that can do workforce? And it ended up with me. And I felt so privileged to work on this issue. That was about a year and a half ago. And that project was huge, wide scale. The first thing we had to do, which literally I sat down with Lilly Endowment executive leadership, and they're like, so, we were told by the president's office at IU that you are the state's healthcare workforce expert. Can you please tell us how many degree programs do we have right now in the state of Indiana and that are preparing people for these types of licenses for mental and behavioral health? And where are all those programs located? And I looked at them and I said, I'm sorry, we don't have that data. I don't know that that actually exists anywhere. And so they said, that is your first task. We want you to look into that. We want you to get us that list. We want to know how many people are being prepared. We want to know what's going on. We want to know why students aren't going out into practice in Indiana and what we need to do to get our workforce right-sized. So through that, I had the honor and privilege of working very closely with state government, both the Indiana Commission for Higher Education, that's our state agency that does higher ed work, and our licensing agency. I know we got some behavioral health licensees, mental health licensees in the room. You guys have had to work with the PLA, with the Behavioral Health Board, okay? We had to work with them because what's going on with this workforce? It's education and it's also licensure, and we know that. And so as part of this project, we created several dashboards, and I'm sure if you're interested, we'll make sure we get you all of the links to all of that information where that inventory now lives. So Lilly Endowment can now go on and they can look at the degree programs that are preparing people to go into mental and behavioral health careers here in the state of Indiana, and CTS is listed there. Because of course your counseling programs are preparing folks to serve Hoosiers' needs. In addition to looking at the degree programs and the enrollment and graduation trends from those programs, how many people are we developing as a state to come out into our workforce? We also had to understand what was going on with those trends and what the challenges were, and most importantly, what are potential opportunities or solutions. And so as part of that, we reached out to all of the degree programs, and that brought us to CTS to learn about the programs that you all have here. And so we had to engage with every single degree program in the state of Indiana. So that was a huge undertaking. We have, I think, over 150 different degree programs that prepare folks, different types of degrees. Psychology, because this included psychology licensees. We have psychiatry residency programs. We have counseling programs, marriage and family therapy programs, you name it programs. If you go on the inventory, there's more programs than I ever knew existed, okay? But the problem is, many of the people that graduate for those programs do not go on and become licensed and provide clinical care in our communities. So we had to understand what was going on with that pipeline, right? People are getting into it and they're going through degrees, but they're not coming out and going into the types of jobs that we need to care for people in our communities. So we had to connect with the degree programs, and we got to connect with your fabulous faculty here to learn about your program, just the same as we did with Indiana University, Purdue, all of the different degree programs across the state. As we did that, we identified huge challenges, okay? I'm just gonna be honest, a lot of them come back to money. I mean, we all know a huge thing is funding, right? Okay, if you want students to go in and then you want them to come out of their degree and go into practice, especially if you want them to work with underserved populations, we can't expect them to have, $150,000 of student loan debt and then be able to go into mission-oriented practice. That's very hard when you have to pay that back. So scholarships were identified as needed. One other big thing is faculty shortages. A lot of degree programs quite simply said, hey, we would love to train more folks, but you know what? We don't have enough faculty. And it's a vicious cycle because there are a lot of clinicians that could become skilled or be prepared to serve as faculty, but that takes away from clinical practice, which means our shortage gets worse. So it's a vicious cycle. There are faculty shortages. Also, faculty don't make as much as you can out in private practice or practicing. And so it is really hard for people to say, sure, I'll step out of my practice, serving my patients, and I'll come into a faculty role. It's challenging. So opportunities for funding for faculty were identified, scholarships for students, all sorts of solutions like that. One of the other challenges that we identified was clinical training opportunities. So the individuals that go through these degree programs, and I'm sure I'm talking to people who did it, so they have to get clinical training experience. If you're going to be someone who's going to be providing clinical counseling to individuals, you have to do that as part of your training. Just like, at least in my church, we have vicars come through every year, right? It's kind of like their clinical training is they come for a year and then they go back and finish their seminary courses. But students have to complete clinical training preparation while they're in their degree program. And then with these mental and behavioral health fields, they graduate, they have to complete 2 more years of clinical training before they can be an independent licensed practitioner. And we identified that those clinical training opportunities for students are limited. A lot of degree programs reported, we don't have clinical training experiences, we don't know how to get them out there. In fact, we worked with licensees, so if you're a licensee and you received an email from the PLA asking you to share your experience with your education and your clinical supervision, that was part of this project and study. And licensees reported some of them graduate, they didn't feel like they had the clinical training in their program, that they were prepared to even know what it was like to go out into practice. And so we have shortages. Some degree programs are reporting we can't get enough clinical training partnerships and programs. Then we heard about CTS, and I'll remember the day that we had a meeting with Dean Lozado and I think someone else on your team. And you shared with us, you're like, well, we operate a community clinic. Our students get to do their clinical training right here with us, with their faculty. And then, when they graduate, they can stay and get clinical supervision here. I was blown away. I'm like, what? Wait a minute. I'm talking to Purdue, I'm talking to Evansville, I'm talking to, IU, my own institution, and they're saying, well, we don't know what to do. And here, CTS, a relatively small institution, has developed its own solution. So I was really excited for the opportunity to elevate the fabulous work that CTS is doing to help develop the workforce. I think that the model that you all have, that the investments you're making in educating the next generation of our counseling professionals, and not just educating, but also equipping them with those clinical skills is so important. And I felt honored to elevate that statewide. Apparently, I was told, an article and piece came out on NPR this morning where I was actually talking about CTS. So I guess you guys can check that out. And that was not intentional somehow. I did an interview like a week ago and it literally came out today. So you guys can check that out. But I want you to know, and I want you all to feel encouraged that what CTS is doing is making a significant impact. And I believe that your model should serve as a model for other institutions to create their own clinical capacity, to serve their students, to serve their community. Addressing our workforce shortages is a critical piece of addressing the crisis of untreated mental illness. People who are suffering, they need to be able to find someone to go to. So, just like right on time. So I think I want to leave you with some thoughts. I am not a mental health professional. I have not taken any theology classes. But what I do know, and what I do know the research shows, is that people who are connected, people who have social connections, they are less likely to struggle with mental illness. They are more likely to get access to care. This is especially true with our women in the postpartum period. There is a ton of literature that shows that women with greater social connections in the postpartum period experience significantly less postpartum distress and different issues. As communities of faith, as people who are preparing to be faith leaders, or as people who are preparing to be counselors and do faith-based counseling, we have to recognize connectedness is so, so, so important. And I can see the impact of the connectedness of my faith communities and the impact they have had on my life and on the life of my family. So for faith communities, for faith leaders, we need to work on connectedness within our community. That means addressing the stigma that exists. That means boldly calling it out and working to reduce it. And I know that can be a challenge. Also, I think another call to action is, there's a lot of literature that shows that spirituality is so important and actually can be protective and healing for our mental health and well-being. Our communities of faith, our religious institutions, they are the places that foster and cultivate our spirituality. And so they are a place that we should talk about mental health, that people should feel comfortable sharing if they're struggling. And then finally, because I'm a policy researcher, I think a huge part of the solution is policies that support, advance, and recognize the workforce, the peoples, and everyone that's involved in lifting up and reaching out and caring for all of the people that are struggling with mental health. I hope that this was a good talk for you guys. I was very anxious to speak to you. But truly, it is an honor to be here today. I need you guys to know I was preparing this and I'm reading up on stigma, and I'm like, I am a woman of deep faith, and my faith has defined every moment of my life, including, I believe, it defined this moment as well. Sometimes I feel stigmatized to say that I am a woman of faith. I can feel isolated in that. And so I want you all to know that it is so important that we be bold in being comfortable with being peoples of faith, whatever our faith backgrounds are, and being comfortable with that and reaching out and caring for people that are struggling and suffering. So thank you so much. I'm happy to take any questions.
We'll take a moment here to do some Q&A, but let me move over here. Okay. I have a confession too. I am not a therapist. I'm not a counselor. And when David asked me to go to the meeting there, I had imposter syndrome. I said, what am I doing here? But I was very committed because I have mental illness within my family as well. I've seen it with my parents. I've seen it with family members. And in the Latino community, it's very much stigma. It was stigma very much within my Catholic community where I was part of. So I resonated with that very, very, very much. Questions? Any questions? Yes, let me project. Okay.
Well. Can you hear me?
Yes.
Yeah.
Can we have access to your slides or
Absolutely.
because those stats are really important to get out to our congregations.
Absolutely. I will send you I'll make sure you get the slides. I will also make sure that they get the link to the full playbook. So the project I shared is called the Playbook Project. And you guys, we called it that because a lot of people love sports in Indiana. Okay, we're like the amateur sports capital of the world. And so I was like, we need a playbook for our mental and behavioral health workforce. All of the stats are presented in that report with all of the source data. So I'll make sure that you guys have all of that information. I want to also offer to serve as a resource if you have questions about information that you can share, obviously about policy and data and the workforce. But if I can be a resource, please let me know. I would be happy to do that.
That's terrific. Has this been recorded, your presentation?
Yes, I believe so, right?
Yes.
Yes, okay, yeah.
Is it possible to get a link? Or
I think so.
On YouTube,
We'll put it on the CTS YouTube page, channel or page. Yes.
You mentioned a number of institutions who give the degrees but don't have opportunities for clinical apprenticeships. Why couldn't the state make it a requirement that they have some kind of clinical connection for their students?
That's a really great question. the university has to provide the education required for the diploma. So our public institutions are required to satisfy the diploma requirements for the degree. I think where challenges come in, especially with some degrees, okay, sorry guys, this is getting a little technical, and especially with Master of Social Work degrees, which just happens to be the biggest volume of our behavioral health degrees that we issue as a state, there are flexibility within the curricula for that degree that can kind of make it so that they don't necessarily have to complete a specific clinical training to a volume. So it's lesser about what the state can require, and it's more about what the degree programs can make sure that they're preparing the students with. A lot of our counseling programs have those clinical partnerships already. Where we have a very big challenge is our Master of Social Work programs. And there are people that get a Master of Social Work that don't plan to pursue clinical licensure. So our Master of Social Work graduates can pursue the licensed clinical social worker, which is a clinical counseling license, but we have a lot of people with Masters of Social Work that can go in other places. It just so happens, though, that the biggest pool of our clinical counselors are coming from social work. So it truly has to do with our Master of Social Work programs. And so what I didn't go into, because CTS does not, I don't think you all have a social work program, but that's a whole nother discussion about social work and social work degree programs and the development and establishment of clinical pathways for those students, because that is what is missing. And the degree programs are reporting they don't have the clinical training partnerships to establish those clinical pathways. Now, I'm going to say this. I'm sorry, I'm going to take a moment. I know I was done, but I'm going to take a moment. I believe faith-based organizations can help create those clinical training opportunities. East 91st Street Christian Church actually has a mental health clinic, and they almost fully staff student interns and individuals completing clinical supervision. So the E91 model of a faith-based organization making an investment in creating a clinic for their community, but also being dedicated to having opportunities for students to learn and get clinical experience. I believe there's opportunities for our faith-based organizations in the state, especially those that are well-resourced, to look at that model and say, is this something that we should do and could we partner on? So thank you for asking that question. I hope that I answered it sufficiently.
Dr. Maxey, thank you very much for your presentation. Very informative. My name is Dr. Matthias Bayer, and I'm one of the faculty here in the Clinical Mental Health Counseling Program. I want to just piggyback a little bit on what you just said about clinics. One of the things that we do actually here also is work with community partners to facilitate relationships where people then can, after our degree, in addition to the residency, here at CTS, go into the community. That's one thing. The other thing I want to observe is in this very room, we had the first Indiana State Suicide Prevention Summit. About 10, 11, 12 years ago, I was on the Indiana State Suicide Advisory Committee, and this was a great space for doing this. So it kind of comes full circle here. And I want to thank you for bringing this. What I see when I talk with my students, when they go out into the field, that very often they're completely overloaded because of the shortage. Also, they're supposed to do basically very quick overturn, which doesn't quite address like the despair of death that you mentioned, right? So that's a real challenge often in this kind of lack of resources. My question was, and actually one more comment on the spirituality, because while it can be a protective factor, and religion and mental health research shows that, it unfortunately, particularly in our state, is also a negative factor when people do what you just said. Oh, pray it away, right? Or demonize mental health issues. But my question is, as you have been doing the research, what factors have you found within the communities that are having most shortages? What are the factors that you identify that keep these communities in these very severe amounts of shortage? And what training programs like ours could potentially keep in mind, maybe share with students? That would be really helpful. Thank you.
Thank you for asking that question. So this is not going to be a surprise. Our rural communities, so our counties that are more rural, they struggle with the most significant shortages. And I think a huge part of that is there's just a smaller population, right? So there's a smaller potential patient pool that might not be able to support a full-time therapist, right? So if it's a town of 600 people, or a county of, just a couple thousand people, it's very hard for someone who has, think of students who come out with student loan debt, and are looking to establish a practice, that's not viable. I think that there may be, I'm just shooting from the hip, guys, okay? Just shooting from the hip. I think that maybe there's opportunities for faith-based organizations to look at hosting mental health counselors within their organizations, and maybe rotations. One of the other exciting things that we saw with the playbook, and this is not a faith-based organization, but there's a student at Purdue University who is preparing for I forget exactly what master's degree, but they're working toward a behavioral health and human service license for clinical counseling. And they actually, and their family, grew up working for Tyson, like the chicken plant. And they were very aware of the mental health issues and illness that the people that work at Tyson were experiencing, and that there was no one caring for anyone out there. And so this student actually worked with their faculty and said, I want to do my clinical rotations at Tyson. And the faculty was like, let's do it. And now they're establishing clinical rotations at Tyson and have a faculty that goes out there. So I think that innovations can exist. We just need to identify them and share them, right? So that we can identify which can be scalable. And maybe for faith communities, something like that can work for faculty and students to go out there. And maybe that's a way for a student to say, I might like to be out in this Tri-County area. Maybe I would like to raise a family in this community. If our students don't experience some of those communities, they will never see themselves there. And it's not as though the opportunities exist there. We have to get students to areas so that they can see what opportunities they might create.
I invite you to reject the premise of my question, and with your work I hope you do. But my question is, what percentage of the expenditures that we now undertake from our private insurance and government insurance, along with the dollars we spend on training, if we diverted that into housing support, transportation, food support, would we come up with a better overall mental health than training individual counselors?
Whew, that's like high health economics right there.
Policy person, so.
I think we need an and, not an or. I think we need an and, not an or. I think we can provide housing. I think we can expand, and we absolutely definitely need to ensure that we have adequate social supports for folks, but that will not take care of all of the mental illness and disparity that is around us. I think that we need an and solution, maybe potentially a rebalanced solution, but probably not just a redirect. So.
We have time for one more question.
Okay.
Dr. Maxey, thank you so much for taking this humongous project on. We have so needed this purview. My name is Donna Marino. I'm a grateful graduate of CTS and grateful that you found your way to CTS. I have many questions, but I'm going to try to keep it to 2 or 2.5. I know we only have one, but the first is I am curious what you found about the role of the PLA in helping I guess, move people through the process as quickly as possible. I found myself, I'm a licensed marriage and family therapist here in the community, and I found myself to have experienced bottleneck and a very, very slow process and concerned. And so I'm just curious what your research showed about the role of the PLA, just from a high purview.
Absolutely, I'm happy to. I couldn't address everything in my talk, so thank you for opening that door. I shared with you guys that there was a pulse survey that went out to the licensed behavioral health professionals, inviting them to share their experience. Part of what they were asked to do was to share their experience with their education and their supervision period, but another part was asking about their experience or where they see opportunities or the challenges that they experienced. Licensing processes, confusion with licensure application, confusion with requirements, long waiting times for application decision, unresponsiveness and feedback. Those were very common qualitative information that we received from licensees. And so that information was provided to the PLA. Actually, Dean Lozado can tell you the executive director of the whole PLA was there at the meeting. 2 things. The playbook that I mentioned, it has a bunch of recommendations. It also highlights CTS, so you should check it out. But one of the very big recommendations that is hopefully going to be in to the legislature this session, number 1 is regarding adding a new position to the Behavioral Health and Human Services Board that their sole job would be dedicated to Education and Application Coordinator. So the Indiana State Board of Nursing has an entire 1 FTE, and that's all they do. Through this project, we really identified that the Behavioral Health and Human Services Board needs that as well. Although nursing only administers 1 license, BHHS, I think they administer like 10 different license types, and it's very highly complex because each of them have different requirements. So the PLA, I'm very happy to say, has actually included that on their legislative proposal to the governor. And I am involved in groundwork to support that. So hopefully, I know it won't help those of you that already have your licenses, but hopefully your future colleagues will experience significantly streamlined processes.
Thank you so much, Dr. Maxey. Not just our colleagues, but the folks that are needing therapy and waiting for counseling. The second question I'm curious about is if CTS looks like the model that can work, how are other higher institutions responded to that, right? We are a faith-based organization, and I came through the program, so I fully support that it's a phenomenal model, but I am curious how the public sector responded to that.
So I cannot tell you that yet because I don't know. What I can tell you is, obviously I'm at Indiana University, and so after the playbook was done, President Whitten's like, now you can oversee institutional implementation of the playbook. I was like, great, yes, I could do that. And so I am actually meeting with all of the deans of every single school, which we have a lot, of every single school that is involved or has degree programs that are preparing individuals. And literally, I'm going to be convening them in October, and that's one of the things we're going to be talking about. So stay tuned for that. What I can tell you is every single interview that I'm doing, I am making sure that I mention this CTS model because I think our public institutions, that should be an opportunity, and I think that they probably have funding opportunities that can help support them to develop that.
Thank you. Just a comment. I know I'm hogging the mic. And what role, this is not a question for you, but just a general question to the CTS staff. What role perhaps can CTS play in bringing the faith-based community and the mental health community together to start to address this disparity in the community? It's just sort of a pondering thought. Thank you.
I'm happy to let you all take that. Maybe that's another day. So, thank you. I think we're past 5. Okay. Thank you all again so much for inviting me here. Thank you for listening. Please let me know if you need anything.
There is a reception, so if you have any other questions, feel free to ask Anna at the reception. So thank you very much.